Today, we'll be broaching the question of which healthcare systems in the world are working, which aren't, and why. I'm Ray Suarez, the moderator for today's program, one of the hosts of World Affairs on KQED and wherever you get your podcasts, and the Washington reporter for Euronews. I'm delighted to introduce our speaker today, Dr. Ezekiel Emanuel, Vice Provost for Global Initiatives, the Diane Levy and Robert Levy University professor, co-director of the Health Transformation Institute, and on leave as chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. From January 2009 to January 2011, he served as the special advisor for health policy to the director of the Office of Management and Budget in the White House. Dr. Emanuel received his MD from Harvard Medical School, his PhD in political philosophy from Harvard University. Welcome, Zeke Emanuel. It's great to have you with us.
Lovely to be here. Thank you, Ray.
Do national systems tell you about nations, about their people, and about what their people think is important? When you do this comparative study of healthcare, do you learn something about the country?
I think you do, because every healthcare system has evolved over time, and they have very different characteristics. And those characteristics are a result of politics, value choices that different countries make. And it certainly reflects how they go about enacting social programs.
So if people in one country are happy with their system, it doesn't necessarily follow that if you simply transplanted it somewhere else, the people in country B would be happy.
Oh, no, you cannot, what one commentator has said, lift and shift healthcare systems, just like you can't lift and shift lots of other systems. And the main reason is that there are different values, but more importantly, there are different institutional structures that have been built up over time, and they both enable certain reforms, but limit the kinds of reforms you can have. The political scientists call this path dependence. And it's one of the reasons that we didn't start this study of other healthcare systems trying to look for what we can sort of import to the United States whole cloth. We look for more selective aspects that might be able to inform the reforms that we might make to our system, like drug pricing or long-term care.
So are you saying there's certain rigidities that we have to take account of, that even if something's a good idea and works and the numbers work, it wouldn't necessarily be something you could put in place because the past makes a claim on the present?
Yeah, sounds like you're a PhD in political science there, Ray. I think that's exactly the right phrasing. There are rigidities, institutional structures that limit the kinds of reforms that can be implemented. And those, by the way, there's a sort of feedback loop. Those institutions reinforce certain values and reduce the impact of other values. And that shapes what you can actually do. And one consequence for example, lots of other countries do very big reforms, their parliamentary systems. The new party comes in, they just change everything. We don't do that in the United States. And as a consequence, we have more incremental reforms. Even our big bills tend to be incremental. And that ironically leads to a lot of complexity in our system, and almost every other system is less complex than ours. That's a sort of cultural value we have.
Well, I was fascinated when reading your book to see just how many variables you compare as you look at different countries. The number of nurses in a population, the number of doctors in a population, what they get paid, what percentage of the overall healthcare bill goes to pharmaceuticals, and on and on and on. Do these substructures really, to a degree that we don't even take full account of, dictate what's possible in healthcare? For instance, in the United States, we have about 2.5 doctors per 100,000 population, but who becomes a doctor is a little rigid, is a little controlled almost in a guild way by current doctors. You can't just throw open the doors and bring thousands and thousands of new doctors on stream that easily. Does that fact, the number of doctors, sort of reach out and affect anything else you try to do
Yeah, yes. First of all, I
in
think
the
it's about
system?
I think it's about 2.5 doctors per thousand, not per 100,000. And it
Oh,
does
sorry,
affect.
sorry, excuse me.
Not at all. I just don't want the audience to get the wrong impression
Yeah,
that
right, right. I
doctors have
misspoke.
left America. um, it does have a big effect on the kind of structures you can create, and also the trends. I mean, I'll just give you one trend that is sort of common across most, but not all countries, which is a decrease in hospitalization. So we probably led the world on this beginning in the early 1980s. Fewer and fewer people admitted to the hospital for procedures. And procedures, hospital admissions, we've done care in other venues, nursing homes, skilled nursing facilities, rehab hospitals, and increasingly in the last few years, and I think increasing in the future, we're doing much more complex care at home. Now, other countries have done that a little less, but there are big differences. For example, Germany still has a huge number of hospital beds per population compared to the United States. And China, there's almost nothing but hospitals. There are almost no physician offices. They don't have that. So if you want to go to see a doctor, you go to a hospital, and doctors have to be affiliated with the hospital. Well, that creates lots of rigidities in their system. Most of their health policy people think that's a mistake. They'd like to get people to go to physician offices, but they can't get the great doctors to move out of hospital care. And ergo, they've got a sort of vicious system. So if they want to expand access to care, they have to build more hospitals. Terribly inefficient. And we saw this during the COVID crisis where, overnight they built 13 hospitals, but, it's a huge waste of money.
That approach in the United States, less resort to hospitalization, is that forced by cost considerations or really by quality of care considerations? Who's got the whip hand here? Who's making the decisions?
I think it's actually, it probably originally was driven by cost, still driven by cost, but I think almost everyone recognizes it's a good thing. Maybe sometime in the past, going to the hospital was like going to the spa to recuperate. No one thinks going to the hospital now is like going to the spa to recuperate. You're worried about hospital-acquired conditions. There's falls. There's being woken up every minute during the night, so you can't even get a good night's sleep to recover because the nurse has to take your blood pressure and your temperature and make sure that you're there, or some monitor falls off and they rush in worried that your heart's no longer beating, only to find out the stickiness fell apart. So it's not a great place to recover. There's a lot of data, studies called hospital at home, where you take patients and you randomize them. You either put them into the hospital for a problem, or you send them home with a nurse, the ability to do lab tests, doctors even visiting. Patients at home recover faster, they get fewer tests, and they actually like it better. So it's probably originally driven by cost, but now has taken on a life of its own because it's probably also higher quality for patients for all the reasons that I mentioned. And there are a lot of changes in the healthcare system that are very similar to that. Initially, we did surgery outside the hospitals in these ambulatory surgery centers because hospitals were expensive. But now people are realizing that's also probably a better thing to do.
When you compare the United States to other systems around the world, by far and away, Americans, one way or another, either they pay out of their own pockets or there are proxy payers, but we pay more for healthcare out of our gross domestic product than any people on earth. And we arguably don't get great results for that money. We die sooner, we have chronic conditions that get diagnosed later, and so on. How much of that cost is a direct result of the complexity of our system? I've lived in other countries, I've gotten healthcare in other countries, and I got to tell you, it's pretty simple to get treatment in some places in the world because they tell me it would actually be more expensive for us to figure out how to bill you than just give you this treatment.
Yeah, it's a great question. It is true. We're at 17.9%, 18% of GDP for healthcare. Other countries, even rich countries, Germany, Switzerland, Norway, are in the 10, 11, 12% of GDP range. So we're 50% higher than other rich countries in terms of what we spend. A lot of that is a result of prices. We have much higher prices for everything. Recently, one of my research assistants had a concussion, went to the emergency room, got a CT, and the bill was $6,000. Now, we won't pay, the insurance company won't pay $6,000, but the idea that a CT scan is $6,000 is ludicrous. You can go to other countries and get it for $100, $200, $300 kind of range. So we're not talking about even a tenfold difference, more than a tenfold price difference. So our prices are way high. Our nurses make the most in the world. Our doctors make the most in the world. All the prices along the way, as you pointed out, drug prices are higher. So that's part of the big difference between us and other countries. But as you point out, there are lots of other differences. It's estimated that in this bucket of what we could save is about $1 trillion, somewhere between 800 billion and $1 trillion per year. It's a shockingly high amount of money. Just imagine what the United States would be if we could spend $800 billion on other things, whether it's better education, early childhood interventions, investment in research. It's a huge waste, and I've been writing about that huge waste for at least more than a decade, probably 15 years. And that's made up of many different components. So one component is unnecessary services, surgeries you shouldn't have had, or devices that shouldn't have been implanted, that don't add to your health at all. There are lots of cases of that, worth several $100 billion. There's also what should be called inefficient care. That is, care that you use a technique that's more expensive, even though the cheaper technique would be just as good from any health standpoint. And let me give you two examples, both from cancer, because maybe you mentioned it, but I'm an oncologist, so I think in terms of cancer. One is a drug. So there are lots of cases where a generic drug is just as good as a brand name drug. Just as good. There's no difference. The generic drug is much cheaper, and yet there's a lot of cases where oncologists will say prescribe the brand name drug instead of the generic. One good example is in chronic myelogenous leukemia, a disease of older people. It sort of smolders for a while, and then people used to blast off and die of an acute exacerbation of the leukemia. And then along came this drug, which some of your audience may have heard, called Gleevec, developed and pioneered by a friend of mine. And Novartis had the patent on it, and then it's gone off patent. And so the price went from like $90,000 a year down to $3,000 or $4,000 a year. But there are 4 other drugs in the same class that do exactly the same thing, and they're super expensive. But you could prescribe Gleevec for $3,000 instead of one of these other drugs for $90,000 or $100,000. That's inefficient if you don't prescribe the cheapest drug. Similarly, for breast cancer, there are women who have a nodule. You remove the nodule, you give them radiation because the nodule is small. You could either give 3 weeks of radiation, slightly more intense, or 7 weeks of radiation. They're exactly the same from a survival standpoint, the chance of recurrence of the breast cancer, and from a cosmetic standpoint, how the breast looks after the treatment. Exactly the same. We've got 4 randomized trials going out 15 years. In America, 2/3 of women get 7 weeks. Why? Doctors make more money if they prolong the treatment. That's inefficient. 3 weeks would do just as well, and it's cheaper. And there are many, many, many examples like that. And then, as you point out, Ray, the other big category is administrative costs. Administration on the part of insurance companies, administration in the doctor's office, administration at the hospital level. We have lots of, and that's because we have multiple insurance companies, we have the government program, and they don't exactly align, and there are very different things that they're asking doctors to do. So filling out the paperwork for the insurance company adds costs. Patients filling out paperwork adds costs. That's hundreds of billions of dollars. It's estimated hundreds of billions of dollars. So we could simplify that system and save hundreds of billions of dollars. So that's a third major bucket that is different: unnecessary care, inefficient care, and administrative and complex care, complexity to the system.
I have to tell you that during the two grand battles royale over healthcare, the Affordable Care Act and the Hillary Clinton, Ira Magaziner, early 90s version of healthcare reform,
You're dating yourself, Ray.
I totally misread the play because I thought, well, who's gonna go to bat for insurance companies? People hate their insurance companies. They can't get answers. They can't find out what they're covered for and what they're not. They routinely have to change practices because practices go in and out of coverage. People are complaining to me all the time. People in PPOs pay money up front and then wait months to get reimbursed. Who's going to say, wow, I really want to save my insurance company? And the politics of it was managed in such a way that people clung to their insurance companies. So I was completely snookered on that one. I said to myself, oh, this is going to work because people hate their insurance companies. I'll tell you a quick story. When my son was young, he was recommended to have surgery on the back of his throat and to stop troubles with breathing and troubles with sleeping. And he was a little boy. And he was terrified of being in the hospital, of going to the hospital. We got cleared by the insurance company. He had the surgery early in the day. He came out from anesthesia. He was awake. He was fine, but was crazed by being in the hospital. So that evening, the doctor said, you know, he's not going to sleep a wink. The kid's a wreck. Take him home. We went home. We came back the next day, he slept in his own bed. We came back the next day. They checked the stitches and all that. And then 2 weeks later, we got a bill for the entire cost of the surgery from the insurance company because they said we had changed the terms of the procedure. We had changed the terms of the pre-clearance, and now we were on the hook for the entire cost of the surgery. Our surgeon went to 2 appeals to bat for us to say that that was ridiculous, that it was his medical opinion that actually staying in the hospital was going to be worse for this kid than going home. And we lost. And we paid a great big bill for the insurance out of pocket, defeating the whole purpose of having insurance. But also, you wonder, when I tell friends in foreign countries that story, they're slack-jawed. They can't believe it. And that's the triumph of bureaucracy over medicine, it would appear.
Absolutely. And I have a story almost identical, slightly different, for a patient I took care of with cancer, very advanced cancer, who really insisted that she get treatment and really didn't want hospice, repeatedly offered it to her because she thought that was giving up. And so I talked to her husband, who really didn't want her. And she really wasn't appropriate. She had advanced so much that she wasn't appropriate for any additional treatment. And I said, all right, well, won't call it hospice. We'll give her home care. And her insurance company was like, we're not approving this home care. I said, listen, if I admitted her to the hospital, you wouldn't bat an eyelash. I could say that, she had pain, whatever it is, she wasn't eating. She would need hospital level care, and you wouldn't bat an eyelash, and you would pay that high bill. This home care is going to be cheaper. And they had these rules, these crazy rules about how much home care she could have, but hospitalization, which would have been way more expensive, they wouldn't have, resisted one iota. I finally convinced them. I said, if this gets out into the press, you are like going to be toast because it makes no sense and you were paying more. So they finally relented, but you're absolutely right. There are crazy rules, and people in other countries don't understand this. Let me just give you an example. One of the things we cherish in America is choice. I should have choice of doctor. I should have choice of hospital. I should have choice of insurance company. And we think somehow we've got all this choice. Let me tell you, we got nothing. And we got nothing compared. My best example is Germany. I went to Germany and I, began interviewing everyone, try to understand the system. And one of the doctors says, yeah, there's a patient here. They've got, say, a bum shoulder or a knee. They want to consult an orthopedist. They could go to 10 orthopedists in a day, 10 different orthopedists in a day, pay nothing, right? Totally covered, right? They get unlimited choice. Any doctor in the country, any hospital in the country. So, Germany's a system not that dissimilar from ours in that people select a private insurance company. The government pays the private insurance company. Patients have to pay a little premium to it, but they cover lots of choice. They cover every hospital in the country. So, there are complaints about Germany, lots of them. I mentioned one, they have too many hospital beds. There are some other important problems that they have, but choice, they've really put it front and center, and also paying at the point of care. We pay a lot, right? You go to the doctor, $50 copay, $20 copay, whatever it is. Many countries have either $0 or $10, what the equivalent of $10 copay to see the doctor. Canada, it's $0 at the point of care. Britain, Germany. So there's a lot to be seen at other countries and a lot to learn that we can do. And this principle that you pointed out, let's reduce the complexity. Let's simplify the system in America. That will make everyone's life better, and it would also save money. And I think that's something, policymakers need to think a lot more about.
If you are interested in this part of our common life, you should definitely read Dr. Emanuel's book, but I will ruin something for you. And he doesn't make you wait either. It's as early as page 7, where he admits that there is no one best healthcare system in the world, even after calling his book, Which Country Has the World's Best Healthcare? But you should read on past page 7 after he eliminates the suspense. One thing I learned, if I learned anything, was that if you push down on one thing, something else unexpected comes up somewhere else. That it's not just a question of, for instance, widening choice or reducing choice or lowering this cost. Something else compensates somewhere else. Are there systems that have, responding to politics and also to the realities of healthcare, try to massage public desire, the realities of medical provision, and get pretty good results? Are there some systems where you said, for these people, this works?
Yeah, we did at the end of the book. We do point out that there's no ideal system. And part of the reason for that goes back to, I think, your first question, Ray, which is, look, a lot of it depends upon what you value, what is really important to you. And that will shape what the system emphasizes and what it doesn't. And we identify 22 different, metrics that you might look at. Comprehensiveness of benefits, not paying at the point of care, the latest technology, free choice. There's lots of choices. You can't have everything. You can't optimize on everything. But a lot of systems do optimize, I think, on what many people want. They want comprehensive benefits. They want high quality care. They want choice, if not completely free choice, at least choice of primary care doctor. They also, want to be protected against catastrophic payments, low cost at the point of care. And so different countries optimize. We did end up identifying a group of 4 countries at the top, but each of them, if you ask me, I can point out things that I think don't work perfectly. Taiwan, ironically, has a system that almost everyone who's experienced it really loves. But for Americans, I think would be a bit of a jolt. I mean, you can go in and you can order yourself an MRI actually there, and the system will pay for it. But it's a system that believes healthcare is a necessity. We're going to cover needs, and we're not going to cover luxuries in the system. So, for example, if you go to a hospital under the system there, people have described it more like a graduate school dorm. pretty bare bones hospital bed. Your family is supposed to take care of you and feed you. And, nursing care is not what we have come to expect. There's certainly no cherry paneling in the lobby. You pay extra for that. You buy a special insurance product for that in Taiwan because they view that as a kind of luxury of healthcare that the country and the basic healthcare system shouldn't cover. But as I said, you can go to doctors, you can order tests yourselves, and the cost is unbelievably low. I mean, their whole system is runs for under 6% of GDP. But the other real big downside, besides these sort of bare bones hospital rooms, is doctors see 60, 80, 90 people in a day. So you don't get a lot of time with your doctor if you go there. And the doctors are the ones who are really, if you want to say who's really bearing the brunt of the system's defects, it's sort of doctors. And there is a high level of doctor burnout. But, if they increase the percentage, 4 or 5% to say 10% of GDP, they could solve a lot of problems that they have as perceived from the outside. We also selected Norway, which has a lot of positives, but one, you might say, so you can choose your primary care doctor, but once you go to the hospital and get a specialist, you have less choice. It's more assigned to you. And they also have waiting lists for surgery, like cardiac surgery or cataract surgery or hip and knee replacements. And that, you can look at the waiting times, hospital to hospital around the country, but they haven't been able to solve that problem. And to some degree, they've begun sending people overseas to solve that problem. Germany, as I mentioned, lots of free choice. Doctors will complain that, look, I put in a bill and sometimes I don't get paid. The agreement, they cut it back because too many doctors have put in bills. So they have a way of controlling total costs by which on a quarter-to-quarter basis, they can reduce what they pay the doctors, and doctors really resent that. We've provided the service in good conscience at this price, and now you're cutting back. But they also have a very effective drug price regulation system where they won't pay, if a drug is the same, another statin to reduce cholesterol, it gets charged the same as every other statin. You don't get some premium price or drug company. You can't just establish whatever price you want. You have to show that your drug is a health benefit. It goes way over what the other drugs on the market are doing. And then, the Netherlands is also a very good case. And both the Netherlands and Germany have, healthcare is organized and delivered by private insurance companies. You get to choose your private insurance company. The government collects most of the revenue, although in each country, individuals have to pay premiums. And but you get the choice, and it's privately run and organized. And I think that's most akin to the United States. And we should probably move in a direction pretty close to Germany and the Netherlands in terms of how we simplify the system and how we organize it. That'll make a big, I think, could make a big difference in the United States.
There is no bill. There is no paperwork to fill out when you go to see a GP in the Netherlands, and people do it more regularly as a result. And
well, there's here's the pluses and here's the minuses. Mm-hmm. One of the big pluses, as you point out, is no bill. The docs really do know their patients. Also, behavioral health, mental health services, which we're seeing a big need for now in the COVID world. Primary care doctors are responsible, and more than 80% of them have hired specialized nurses to provide mental health visits. And the number of times people go to their primary care doctor to get mental health services has doubled in the country, I think, over the last decade. So they've got actually a very innovative way of providing primary health care. The flip side is their GPs, their primary care doctors, are really tough. And a lot of foreigners who go there complain, I went there with a sore throat and they didn't even give me antibiotics. They're sort of believers, you'll heal. If in 2 weeks it's not better, then you come back and then we'll change it. So a lot of foreigners who go to the Netherlands complain that it seems to be a hands-off healthcare system, a kind of minimalist system. But it's a philosophy in the Netherlands that we don't overtreat. And they seem to be doing pretty well.
They also put an emphasis on strategic preventive care. I went to the home of a couple that had just had their first child. And in the Netherlands, when you have a baby, a home health care nurse
Yes.
spends significant time coming to your house for hours, day after day. This helps them head off early childhood diseases and anomalies. It helps in the adjustment of the new family to having a baby at home. The mother gets more sleep, and they have data to show that that actually aids in the recovery from childbirth. And in the particular case of the family I visited, the woman was having some trouble with the early attempts at breastfeeding. Remember, this was a child that was less than 24 hours old. The nurse was also a lactation consultant because her specialty was visiting these homes where a new baby was present. She was helping the mother get the knack, get the hang of breastfeeding. And this probably saved a tremendous amount of money, even while achieving the desirable, I guess, outcome of being able to send the mother home less than 24 hours after giving birth. Yes, you went home, which lowers costs, but also you had this visiting nurse for several days after delivery. And as I sat in the bustling living room, the husband busy doing this and that, I watched the nurse prepare a traditional snack for a newly delivered mother. It's called cats and mouses or something in Dutch, and it's cookies with pink and blue sprinkles on them. And I said, "Is this part of the deal?" She says, "Oh, I do this in every house that I go to," and it probably costs more in some places and a lot less in others, because if there's early things to observe about a child that's going to need some follow-up, you see it right away instead of relying on a mother who might not know what to look for. So I
Yeah.
saw some appeal there, and I also thought, oh, this would never fly in the United States.
Oh, quite contrary. So let me observe two things about pregnancy and delivery in the Netherlands. I think it's a third, and maybe even more than a third of their deliveries actually happen in birthing centers with midwives, not in hospitals with obstetricians. And they have transitioned a lot of people to that, and same results in terms of, infant mortality, complications, et cetera. So that's something I think we, again, could learn from. The second thing is this nurse early intervention at home, educating the parents, getting them over some hump. It's good for reducing maternal mortality, because a lot of that maternal mortality isn't in the hospital. It's when they get discharged home. It reduces infant mortality, which is the same problem. But we also have studies in the United States where if you provide that kind of intervention, especially to lower income families with less social infrastructure and people who can come and help, it actually is a huge saver for the system. It reduces Medicaid costs long term. It reduces special education needs. It reduces the child's interaction with the criminal justice system subsequently. So there are, as you correctly point out, yes, you might spend some money here, but the system will save money in many other places, often places unanticipated. If all you evaluate, well, did it save the healthcare system money? That may be too narrow a framework for looking at the benefits of these kind of interventions. That's what the research in the United States shows. So I'm actually a big advocate of what we often call in the United States nurse-family partnerships for the whole first year after a delivery of a baby, especially to the Medicaid population. And you're 100% right. This is something done in many other countries that we could learn from.
One fascinating part of the American debate, and this is certainly something that's applicable to other countries, we try to figure out how the human being responds to costs and benefits. We try to bring a psychological framework to decision making. And I've always had it explained to me by people who oppose nationalization, who oppose single payer, that market rationality never happens because people don't make decisions based on good, rational thoughts about costs and benefits. But if you try to apply that to the American system, you never know what anything costs. You never shop anything. The way the system is set up almost precludes trying to find the best result for the lowest cost. Nobody calls a hospital after it's found that they have glioblastoma and requests the cheapest brain surgeon. Nobody says, oh, give me the drug that works most of the time but is a lot cheaper because it may work in my case. You are insulated from actually making any costs, but even cost decisions. But even if you tried, you really couldn't. When I was hospitalized recently, I noted that one gabapentin pill they charged me $55 for. Now, that was silly. Nobody thinks a gabapentin pill costs $55. And I guess the room and the nurse and the little plastic cup that they brought it into me, they're all costed into that $55 for a gabapentin pill. But it is impossible to compare like to like. It is impossible to compare procedure cost to procedure cost. And because there is a middleman, even if you get a bill, and in my case for surgery, the bill was for a day and a half hospital stay, just under $100,000. I wasn't paying the $100,000. I didn't know what the final judgment was going to be, what my insurance company was actually going to pay to the hospital, because it wasn't $100,000. Who knows what cost is? Do people in other countries, do they have any way of knowing what their healthcare costs? Can they make decisions based on price? Because we sure can.
In general, no. And in general, they're actually structured, most of the other countries, so patients don't know the cost. They might know their copay for drugs or copay to see a specialist or to be in the hospital, but those in every other country tend to be minimal and capped. And if you're at all financially stressed, every other country has some mechanism, as we do, to limit how much you pay out of pocket. Our limits are much higher than other countries, but every country recognizes that there are, you can really overwhelm individuals with too much cost, discouraging them using the appropriate healthcare services. Now, we have gone way on the other side, influenced again by our values, our value of, sort of free market economics intruding into healthcare. The idea that if we make people have more skin in the game, they'll be more rational about spending. What we know is that if people have more skin in the game, they've got high deductible plans, they do cut back on use of services. They cut back both on necessary services and unnecessary services. So we're not very good as individuals in judging what should we stop. One thing that we often stop when we have a high deductible plan is preventative services. We don't get those immunizations. We don't get cancer screening, which is one reason in the Affordable Care Act, we actually had a provision that preventative services have to be with zero deductible, zero copay, no matter what, whether you're private insurance or public insurance, because we didn't want these high deductible plans to discourage people from getting prevention that would be beneficial years down the line, knowing again this cycle. But the overall price is a mystery in almost every system. And in other places, it's not because there isn't a price, but often it's like folded in. So a hospital gets a global budget and it doesn't break it down per patient necessarily. It really depends on the structure of payment, and the not every country uses per admission or the fee for service system. So it can often be very, very different to figure out the pricing. What people do know is the price they pay, the copay, and we know that in the United States too. And that tends to be, as I said, much, much higher in our country than in every other country.
Have other countries that have gotten wealthier in recent generations moved toward systems that are more expensive because they're wealthier countries?
There is a graph, and I usually tell my students at Wharton, it's the second most important graph in health policy. And it's a graph, if you can imagine this in your mind. On the x-axis is how rich a country is. That's sort of income per person. And the y-axis is healthcare costs per person. And there's a positive line. The richer you are, the more you spend on healthcare. That makes sense. It does suggest that healthcare is not a basic necessity of life, or we don't spend for it as a basic necessity of life. Typically, for basic necessities of life, you get them out of the way, and the amount you spend on them goes down as you get richer. So healthcare often acts like a luxury good, at least economically. And it is the case that richer countries like Switzerland and Norway spend more per person than less rich countries. And that correlation is incredibly tight. It's one of the best in the social sciences, one of the best I've ever seen. And I always joke with my students about how good that correlation is. Now, the United States turns out to be the one country that is way off that line. We spend way more than we would if we were following the other countries in the association between wealth and spending on healthcare.
Because just in the memory of living people, some of the countries you look at went from being either middle-class countries or even poor countries to very wealthy places like Taiwan, like China, like Norway even, which was a middle-class country, but now has a very high GDP per capita. Did their health spending go in lockstep?
Yes. And as a matter of fact, I mean, Taiwan's a good example where, once they became well off, people began demanding more goods. And one of the key goods they wanted was universal healthcare coverage in the 1990s. There was a sort of concatenation of events. They were becoming more democratic. The National Party that had ruled them for a long time after the communists took over in China was losing power. Democracy was coming, and the country was getting very wealthy, and people wanted the services associated with being richer. And one of the core services was healthcare. And that's when they created their universal healthcare system.
We're going to start taking questions from our audience now. At the bottom of your Zoom screen is the Q&A function. You can put your question right in there, and we'll pass some of them on to Dr. Emanuel. Anonymous asks, are there particular features of health systems in other countries that you studied that have given them a leg up in managing COVID-19 well?
The answer is yes. And I would particularly highlight Taiwan, which for those of you who follow these things intimately, they have just over 500 cases in a country of nearly 24 million people, and 7 deaths. Not 70, not 700, not 7,000, not 70,000, 7. And yet they should have had a disaster. They're not far from China. They have 1 million people from Taiwan working in China. They have air flights back and forth. They averted it. And one of the reasons they averted it because of essential element in their healthcare system. They have a health card that everyone gets. When you go to the doctor, it's swiped. Instead of filling out all those forms like we do and having our insurance cards Xeroxed and then the person keying in our number, they actually have a card that's swiped. So they know why you're at the doctor, the Central Ministry of Health. They know why you're at the doctor. It allowed them to merge the health cards with travel, so they knew who was in Wuhan, China, and who should get tested for COVID right away. They also were then able to identify people who went to the doctor for respiratory conditions, shortness of breath, cough, but didn't have flu, and they again got them tested right away. So they were able to get their arms around COVID absolutely fast because of this real-time data ability due to their health card. I think that is a innovation we ought to have in this country. So I work with a lot of healthcare systems and insurers. And one of the things that's a problem is getting reliable data on what services people use. It's 90 days or 180 days after people use a service that we can get reliable data on that is not real time. That is not the 21st century, computerization system. We need to be able to get that real time data. And by the way, we need to stop asking people, for the same basic information and Xeroxing the card and then someone plugging it in over. I mean, that's 1970s technology. That is not 2020. And we need to upgrade our system. And, one of the reasons we should do it is COVID and that kind of ability to find hotspots very quickly and to figure out what individuals are accessing the healthcare system.
Ravi asks, of the three issues, unnecessary care, inefficient care, and administrative burden, is there one of these areas that has low-hanging fruit to attack?
All of them have low-hanging fruit to attack. I would not say, just focus on unnecessary care, or focus on low, inefficient delivered care. I would say that there are parts of unnecessary care and parts of inefficient care that are low-hanging fruit that we should develop and really wring them out of the system. Administrative costs are a little more complicated, and there are things that can be done to reduce administrative inefficiencies substantially. But then one of the big things that's going to have to happen is we're going to have to harmonize Medicare with the private insurers, with Medicaid, on how they bill, what they pay for, the quality measures that they're getting back from doctors. That level of coordination, that's not low-hanging fruit, but that is, there's a lot of money in there.
Paul asks, when people talk about market-driven solutions for healthcare, are they talking about the healthcare market before the Affordable Care Act? If not, do we know how it would be different?
I'm not sure exactly. I mean, when people talk about market-driven solutions, one of the things they talk about is that people should have more information on cost and quality and make smarter choices and have some of their money at risk. That, as I mentioned, is not typically very effective. It does reduce utilization of services, but it doesn't eliminate only unnecessary services for lots of reasons. We're not good at knowing what our problem is and what the unnecessary services is. We also don't have the information on costs, and we're unlikely to get effective information on costs for exactly a reason Ray pointed out. There are bills, right? What you get charged and what gets paid, all different by different insurance companies. So it's a bit of a problem to actually say, what does, that surgery cost? Well, it turns out there is no cost to it. There's the charge, there's what gets paid, and what gets paid can be very different depending upon who's doing the paying. Is it a private insurance company, Medicare or Medicaid? And so saying what the price is impossible for people. But there are particular places where you can do more market-oriented approaches that can make a difference. Let me give you a few examples. One example is something that was in the Affordable Care Act, which was called competitive bidding for durable medical equipment. Durable medical equipment is like hospital beds at home, that walker that someone needs, oxygen. And one way is the government can set the price, or an insurance company can set the price. The other is ask any supplier, right? That walker is pretty generic. Tell us what you're going to sell it to us. And because you're bidding against all the other potential suppliers, that tends to drive the price down. When the government ran an experiment on that, it resulted in huge savings for both the government and for Medicare beneficiaries. So that's a kind of market you can create. It's not for the whole system. It's a particular focused area. Another one is what's called reference pricing. And this has been used by a number of insurers. The California retirement program called CalPERS has used this for things like hip and knee surgery and cataract surgery, where they say, all right, we've looked around, we're going to pay this amount, $25,000 for that surgery. And here are a number of high quality places that'll do it for 25. You want to go to a more expensive facility that does that surgery, that's fine. We're just paying $25,000. If it charges $35,000, you're responsible for it. Because you could have gone to this other place that would have done a fine job on as measured by our quality standards for that $25,000. That reference pricing mechanism, it works wonders. Again, one of the effects is more expensive places tend to lose business, and what they do, they lower their prices. So that's another sort of market-driven approach that I think is something we ought to look at and adopt more broadly in the healthcare system.
Lurking in the shadows of that big umbrella we call choice, one of the things people want to be able to choose is to do more things in the face of health threat. When during the debates over the Affordable Care Act, people used to refer almost like they were spitting out a curse, something bitter in their mouth. They would talk about rationing healthcare. Oh, that's what they do in other countries. They ration healthcare. The idea being that if somebody actually said, that's not a necessary procedure, or maybe we shouldn't do that to you or your mother or your child, that's a form of rationing. And there's an intimate connection in the American mind, it seemed, with more being better, or the availability of more being better. In other countries, with systems that don't incentivize more in quite the same way, is there a better, let's say, discretion when it comes to necessary care, and particularly end-of-life care, which can be very expensive and drive the overall national health bill?
Separate from end-of-life care, there is, I think many people do have a view that more is better, but I do think we're beginning to understand in the United States that that may not be true. And let me give you a concrete example. Prostate cancer screening with PSAs. That was all the rage, and lots of people, you can see the data. The testing went up, more men got their prostate removed, but then it became clear that really wasn't saving more lives. What you were getting is early nodules that men would die with, not die from. And that, by the way, there are side effects, whether you get surgery or whether you get radiation for that. There's impotence and there's incontinence. And so we've actually seen a drop, pretty big drop in PSA screening, and sort of men taking on board, maybe more is not better here. And that's been I think one of the reactions. But I do think you're right. We have a bias towards more, and a lot of countries, people have a bias towards more. And by the way, doctors, the practice is often, especially among technical specialties, becomes international. It's not limited or localized to one country. But there are some cultural differences. As I mentioned, in the Netherlands, primary care doctors tend to be, why don't we see if it gets better all on its own? And we know lots of things do get better on their own, or do get better with, say, physical therapy rather than surgery. Back pain is a very, very good example where if you, work at the physical therapy, not everyone, but lots and lots of people actually get better without a surgical intervention or without steroid injections and things like that, that physical therapy, chiropractic procedures can actually do well. In our country, I think we're beginning to see that and beginning to sort of internalize it. Now, end-of-life care is a big issue. It's one I've worked on, Ray, you may know, for 35 years now. Beginning in the mid-'80s, I began my career with lots and lots of research on end-of-life care, and it is a big challenge. And I think the biggest challenge is that there's a sort of conspiracy of silence, that doctors don't like to bring it up. Patients are sort of hesitant to bring it up with their doctor. It would admit that, things are going bad. And one consequence is we tend to kick the ball down the road. And we see this, for example, while we've become much more used to, as a country, introducing hospice and having people go on hospice. So now about 60-70% of all cancer patients have hospice care. When I started out, it was in the 20s. But it's still pretty late in the course. So you might get hospice for an average of, less than 3 weeks. Lots of patients are getting hospice in the last 10 days of life. Whereas we need to move that kind of care, palliative care, to treat symptoms, keeping patients at home where they're most comfortable, where they can see their family more frequently, months and months and months before the final event. That we're still bad at. And I think we're bad because no one wants to bring up the subject. So we're going to have to change our system to try to overcome this. It's not taking care away. It's giving people different care. It's giving them more home care, less intervention care in the hospital or at the cancer center. And that, I think, is a trade-off we really need to find in end-of-life care much more commonly.
But the horror stories that are told in the United States that are meant to scare Americans to not try any other kind of system. In Britain, there may be a drug that costs $75,000 a course as opposed to $7,500 a course. They're reluctant to give it if your prognosis is not good.
So I would say those horror stories tend to be stories and not really true. There is the case, and you got places like Britain, Norway, Canada, Australia. They do have waiting times, not for life-saving treatments. Typically, they're ameliorative, cataracts, hip and knee replacement kind of things. Sometimes cardiac procedures, although that's changed with the change in the pattern of care, less cardiac surgery, more, stents and percutaneous interventions. But excuse me, they do have some waiting lists, but there are plenty of places with universal coverage, government paying, that don't have waiting lists. The Netherlands, Germany, France, even, Switzerland. So the overbroad, having government involvement is going to be, you're going to get rationing and waiting lists. Not necessary.
I'll end with one last story because I'm curious to hear what you have to say about it. I was interviewing the head of the Netherlands' largest insurer. And as you mentioned earlier, they're all private insurance companies. And we're sitting in his very plush office, and he's wearing an obviously handmade suit and bench-made shoes. This is not somebody who has to start a GoFundMe page. So it had just been in the papers that in the previous year, the head of American insurer made $24 million salary. And he said, "Did you see this story?" And I said, "Yeah, I see. I saw the story." He says, I'm a very wealthy man, he said, and I get paid a very good salary, but I couldn't show my face in this country if I made $24 million a year in salary. It just wouldn't be socially acceptable in this country. Is there a culturally conditioned part of the conversation about price and costs and all these things that has to do with kind of national personality and things that we would accept in the United States, but just wouldn't go other places?
That's 100% true. So if you look, every country we looked at, there has been widening income inequality, just like the United States, but it's in a much narrower band. So the level of income inequality we have here is substantially more than in other countries, which means that the rich, the people at the top end, the 1%, the 0.1%, while they're much richer than their peers, the band, the multiple of a shop floor worker compared to the CEO is much more narrow than in the United States. As we all know, it was narrow in the United States. Go back 50, 60 years, that multiple was 20 or something between the lowest paid worker and the CEO, and now it's thousands. That is a very big difference. And we have increasingly tied pay of executives to stock price. So if you're talking about an insurance company exec who had stock options, that actually drives a lot of this big pay. And we know that there's been some manipulation in healthcare companies of those stock options. The guy who used to be the CEO, I think 2 or 3 CEOs ago at United, had backdated his options to get more money and was forced out of that system. So I do think that we have in our country permitted much greater levels of inequality. And that is a problem. And you don't see it as much in other countries. And one consequence is it's not just CEOs. Remember, the biggest single profession in the top 1%. It's not CEOs, it's not lawyers, it's doctors. So we pay our doctors a lot. And, they may bitterly complain because they're not in the 0.1% at the tippy top, but we're doing very well. Doctors are doing very well. And we should recognize that in the healthcare system. But it is a cultural attribute. If we were embarrassed to go out because we had made so much money, making a lot of money, more than $1 million a year would embarrass people, and making more than $5 million a year would embarrass people. That would have a very big effect on the whole society, not just healthcare.
That's Dr. Ezekiel Emanuel. Great conversation. Thanks for joining us today.
Thank you, Ray. Great interview.
To those of you who joined us today, thanks a lot for coming along for the ride. We hope you enjoyed today's program. If you're interested in learning more, we encourage you to pick up Dr. Emanuel's book, Which Country Has the World's Best Healthcare? On Wednesday, November 18th, please join World Affairs for the Global Citizens Awards, our annual fundraising event. This year, we're celebrating individuals who've taken bold action on climate change, and in doing so, have helped increase awareness of the issue and moved the conversation forward. Make sure to RSVP on our website. And please, don't forget to vote on or even before November 3rd. Have a great rest of your week. Thanks for joining us. Zeke Emanuel, thanks a lot.
Thank you, Ray. Take care.
Bye-bye.